morning, everybody. I'm Nadiv Shapira. I'm talking to you from my small basement in Wilmington, Delaware. It's a little bit cloudy here, but otherwise it's okay. Thank you for joining us, and I would like to thank Larry Wagner for Chemistream America for putting it together and inviting me for this webinar. I also like to thank three people that I put a picture to give them credit. On the right, on the left side, you see Laura Sunstein. She's a neighbor of mine from Pennsylvania. She's one of the first people, maybe the first one, who underwent liposuction in Germany. I believe it was 1913 by Dr. Stutz, that you see on the right side with me. How can you take this away? No, wait, went away. Did you lose my screen? Hold on.
Yes, we can see your screen, but not your presentation anymore. Should we do that from here? Okay.
No, okay.
Yeah,
can
please.
Okay, so you can see it with Dr. Stutz, and she introduced me to the subject of lipedema. Before I saw her, I really did not know what lipedema is, and we met, and she got me excited, and I met with Dr. Stutz, and he's one of the world experts, probably one of the most busy people in the world treating lipedema. And I went to him to visit him 3 times, and I learned his technique, and he really became a good friend, a good mentor. In the center, you see Karen Herbst, who really brought lipedema to the medical map and really to the attention of providers and patients in the US. So really, many people should appreciate her contribution to the field. Lipedema was described by Ellen and Heinz in 1940. So we are talking about 8 years from now at the Mayo Clinic. What the characteristics of lipedema are really the 5 highlighted features. It happens almost exclusively in women. I have never seen a man with lipedema in my life. It's symmetrical, bilateral. It usually involves from the ankle up, does not involve the feet. You have mild or no pitting edema, especially in the morning, until secondary lymphedema develop. I think the most important characteristic is this fat is tender. This underlying continuous pain, and on top of it, with light pressure or anything that makes discomfort, it really hurts. And very tendency to develop bruising. All the rest features are important, but really, in order to make the diagnosis, it's easy to make diagnosis by these 5 criteria. You do not need any MRI, you don't need anything sophisticated. You can make the diagnosis actually quite easy, and most of my patients make their own diagnosis. They come and they say, I think I have lipedema. I read about lipedema. Do I have lipedema? They come to confirm. The etiology remains unknown, and we feel that it's really underdiagnosed. This is how you get rid of that. I don't know how to get rid of that. Not to touch it?
No.
Okay. The number everybody is talking about is the 11% from Foldy in Germany. There are other studies about the prevalence, but this is the most prevalent figure. I personally believe that it's probably 1/2 of that. But even if you take this number, that means that 16 million women in the US have lipedema. And even if you're talking about 1/2 of that, you're talking about 9 million women. Really, we need good data to ascertain what the real incidence. As I said, it's probably inherited. It's a autosomal dominant path in families from on the women's side, on the female side. This slide is from Dr. Herb. She allowed me to use some of her slides, and I'm grateful for that. There are four stages of lipedema. Here we show the stage 1 to 3. On the left side, you see stage 1. The skin is smooth. When you painful, of course. When you touch it or you have your fingers on top of it, it feels like a styrofoam, small styrofoam balls underneath in the subcutaneous layer. And on the second one, the middle panel is stage 2. When you start to see the irregularities, you can feel different size subcutaneous balls from pea size to pebbles. But the irregularities really start to be quite impressive. And you see stage 2 can be actually smaller than stage 1. So it's not necessarily when it becomes bigger is a higher stage. It is not. There's some correlation, but not necessarily. And on the right side, you see the stage 3 when you have large pockets of fat. Many of them are indurated because of fibrosis, and they're falling all around. And often, well, you see this lady that affects her buttocks and her arms, but it's not part of the stage. As I said, arms can also be involved. Probably about 80% of the patients you have involvement of the arms and buttocks, and sometimes lower percent the abdomen also. There are 5 types for that describe the distribution. I never remember them. Personally, I don't use it. On the right lower panel, you see the typical ankle cuff. The feet are perfectly normal, and above the cuff, the leg becomes bigger. The histology, you have a lot of macrophages. You can see some fat cells are very large, some are smaller or normal, and many times they are clustered together. We used to think that in normal people or obese people, the obesity is due to hypertrophy of the fat cells. But in lipedema, there's hypertrophy and hyperplasia. There are more fat cells. And when you look again, you see the histology, there is some inflammatory changes. You see a lot of macrophages. That's something important because diet and supplement may decrease the inflammatory component of the disease. And again, as I said, you see hyperplasia and hypertrophy of the fat cells. That's important because when you have this thickening of the subcutaneous layer, but this enormous growth of fat, hypertrophy and hyperplasia of the fat cells, obviously it stretches the lymphatic collectors or pre-collectors, we should say, between the skin and the collectors that we are pointing there, that pointed in the slide, and you can see they are stretched, and you see all this microaneurysm in these channels. Very important. Here you see Dr. Herbst palpating the arm of a patient, and when she does, I mean, you pass the finger on top of the skin, and you start to feel these tiny nodules underneath the skin. Wait, doesn't change. Comorbidities. Well, in the musculoskeletal system, we see a gait disturbance because of the fat cell, the abnormal fat pockets in the legs that affect the posture, and that leads to arthritis. I'm not sure we should call it comorbidities. It's more complication of the lipedema. Soft tissue obviously we see a lot of obesity associated with the lipedema, and that's important because of the gait and the posture changes and the arthritis, patients become less active. As they become less active, the lipedema, they gain weight, the obesity gets worse. As obesity gets worse, they have more, there's more arthritis, more gait changes. So it's really like a vicious cycle that really extremely difficult to stop. And really, many women are really doomed by this vicious cycle. Obviously, lymphedema, it's one of complications, the bruising, varicose veins. Hard to say if it's complication of or just a predisposing situation or just associated thing. And of course, what bothers people the most is the pain, the emotional distress, the anxiety, low self-esteem. That's terrible. Actually, Dr. Stutz, my mentor, he presented a paper a few years ago in the National Lymphedema meeting, and he showed a very high incidence of women with lipedema who thought about suicide, and much higher incidence of suicide than normal population. How you differentiate between lipedema or obesity? Well, obviously, history, and as I said, you really can make the diagnosis of lipedema by history and physical examination. No need for any fancy testing. Lipedema usually starts the onset at puberty, but not necessarily. The fat is painful. The bruising is obvious. Lifestyle will not affect the lipedema fat. It will affect the obesity fat, but not the lipedema fat. Lifestyle, it responds. Obesity responds to diet. Lipedema fat not. The associated obesity with lipedema fat may respond to diet, but not lipedema fat. Typically, you see the disproportion between the upper body, and the lower body. You'll see in a minute. You're talking like you have two different people. The upper part of the body is one person. The lower part of the body is huge, and usually there's no involvement of the feet. So we really went through the differentiation, but I mean, when you have lymphedema, this is from Germany, so they say lymphoedema. In America, people say lymphedema, they omit the O. Anyway, so you see the dorsal, in lymphedema, the dorsal part of the foot and the ankles are involved, not in lipedema. The fat in lymphedema is not painful. There's no tenderness. You can press on it. It does not hurt. Phleboedema, or the swelling associated with the chronic venous insufficiency, often you see the discoloration, the brownish discoloration from the hemosiderin deposition underneath the skin. But even if you don't have that, this you really always, the edema is associated with very clear, visible varicose veins. That's a very important slide also from Dr. Stutz. That's a normal posture of patient with lipedema. And you see she's not very advanced. She's probably stage 2, but do you see how the inner thighs are pushed apart? And more than that, the ankles are much further out than the knees. That's a valgus deformity. And therefore, the weight distribution goes not through the middle of the knees and equally distributed between the lateral and medial part of the knee joint, but gradually more and more through the inner medial part of the knees and often between the knees. And therefore the stress is not evenly distributed between all the parts of the knees and more on one side. And that's the reason why so many of them develop arthritis, most of the knee, but some of the hip and of the ankle. This abnormal weight distribution because of the abnormal fat pockets at the inner side of the thighs. And here's the worst case. You see that the right leg is much more diverted out, and obviously this patient had very bad arthritis of the knee and of the ankle. And on the left side, you see that a study was done by Dr. Schutz that he assessed and computerized the point of pressure of the feet. And that's in lipedema patients, most of the pressure is at the medial metatarsal, whereas you see the yellow spot there. Now, never mind. I don't have picture of a normal, but normal people, you can see, I'll try to show you here, that you get hot spot, this area, the lateral metatarsal, and the heel. The abnormal posture lead to that most of the pressure at the inner metatarsal because of the uneven distribution of fat due to the valgus deformity, and therefore there's faster attrition of the joints, primarily the knees. In many patients, the knee pain is a major complaint. Why don't change? Why doesn't change? Okay, that's a patient. That's a picture I took in my office a few years ago. There's a combination. You see, this patient has lipedema, clear lipedema, but look at her obesity in both positions. Look at the upper body. Look, her upper arms are huge, but they are full because there's a combined lipedema, fat, and obesity. The legs, the entire body, the trunk. Look at the lateral position. That's an important picture because if you see, two things I'll point out. If you see this, the lordosis, the lumbosacral lordosis, this is hyperlordosis. The angle is very much smaller than the usual one, and that a cause for many patients. Many patients, it results in a low back pain. That I've seen patients that once you operate and you remove the fat, you do liposuction or these buttocks, the pain in the lumbosacral area resolves. And look at the belly. This is not just lipedema, or maybe even no lipedema obesity. It's mostly truncal obesity. But it's another thing to what this huge belly falls down over the pelvis and it compresses on the lymphatic channels at the groins, and that can exacerbate the swelling or make the drainage of the fluid from the legs towards the up much more difficult. That's stage 4 lipolymphedema. You see on this picture, you can see that the steamer test that you really can pinch the skin without any problem. With when you have lipolymphedema, you really cannot do that. There's another patient of mine. Actually, she's from Iraq, and you see she's somewhat overweight, but you see the huge lymphedema and lipidema of her lower legs, primarily the lower legs. This is another patient. She weighed 330 pounds. She could not lose any weight because of difficulties of walking. So she was really a victim of this vicious cycle. You have more lipedema, put the legs apart, pain of the knee, arthritis, then you gain weight because you cannot conduct active lifestyle, you cannot exercise, you cannot do anything. And one thing to the other. Also look at the hyperloodosis of the spine. And I'll try to show you. I make patients, film them, every patient when they walk, watch them walking. And please notice how she still body from side to side. So look at the genu deformity of the legs and look at this huge belly hanging over the legs. And obviously she has these huge, big pockets of fat at the inner knees. This is probably one of my worst patients that I've seen. She is on diet. She's really hardly eating. Probably she consumes less than 1,000 calories a day, and she's very compulsive. She's really very reliable and really follow the orders. But look at this huge saddlebag she developed, and that hangs over the huge thighs. And the feet are almost normal. She has some lymphedema, but they're almost normal. This is probably the worst patient I have seen. And actually, relatively, you see this abnormal, the upper arms are abnormal, but they're actually fairly empty because she's on a good diet. She's really trying to keep herself healthy. So she does not have much obesity per se. It's mostly lymphedema fat. And this is another patient, very interesting, because if you see all this huge pocket hanging over her right inner knee. And when you lift it, look what you see underneath. You see all these podorange, all these dermatitis and small vesicles of fluid. I show it here. Look, it's red, and when I lift it, it's really, really heavy. It's all fluid. And upon here, you see associated varicose veins, and that's probably exacerbated because of the pressure that this huge pocket pressing on the great saphenous vein. And on top of that, this poor lady, she has this huge saddlebag. This is heavy, heavy. And she's a nurse. She's not working now, but she was supposed to have surgery that we had to postpone because of the coronavirus. A lovely lady suffers a lot. How we treat lipedema? Well, we all start appropriately with compressions. Compressions aim to prevent, to provide some resistance to a leak of fluid from the blood vessels for the lymphatics. It helps the elasticity. It reduces the accumulation of the fluid and decrease the pain associated, because always patients typically say, in the morning, there's less swelling and less pain. During the course of the day, both swelling, tension of the skin, and the pain all increase, and the worse in the evening. And very important that the compression, I mentioned short stretch compression, that helps to restore the function of the calf muscles, because it provides resistance against that the calf muscles contract, expand and retract, expand and retract, and that's what the muscle pump of the legs. But that is subject to another completely different talk about how you manage the edema. And by the way, patients even with reversible lymphedema, swelling, it's considered today by the new definitions as lymphedema. So The conservative treatment of lipedema, just quickly, I mean, food choices is extremely important. And that I love this statement. If men made it, don't eat it. I think there's a lot of truth into that. And with appropriate diets such as paleo or keto diet, patients feel better because there's less inflammation and there's less pain. It doesn't solve the problem, but it helps. It provides some relief. Obviously, trying to be active as possible. Whole body vibration, patients love it because it helps to drain. It helps to mobilize the lymphatic fluid in the lymphatic channels and help them to go up. Wrapping, as I mentioned, very important. Wrapping, I differentiate between elastic compression. Wrapping, at least in my understanding, it's more like with a short stretch, either bandaging or short stretch wraps that you put between the ankles and the knees, and that provides resistant or counter push, I should say, counter push against the contraction of the calf muscle. And 85% of the fluid from the legs is mobilized by the calf muscles. When that doesn't work, usually you have to go to a pump. Personally, I like the FlexiTouch. Lymphapress is very good, and the others. And then, of course, there's all kind of supplements that minimize the leak of fluid from the veins and for the lymphatics, like the butcher broom, diosmin. All my patients get diosmin. Ketoprofen, that also it's like ibuprofen, helps the pain, and guaifenesin, like mucomis, that decrease the viscosity of the edema and makes it more readable to be drained through the lymphatic. So this really, and the other kind of supplements, all the what happened, Lynn? We're here?
Yeah.
Okay. Oh, I'm sorry. Anti-inflammatory supplements are also very helpful. Why it doesn't go? Maybe I'll go here. Hold on. Excuse me. It's stuck. Okay. We talk about diet and supplements. Look, this lady, she's fanatic about eating salads and she's exercise and she's very aggressive. And you can say, I mean, she's basically skinny. If you look from here up, her upper body is tiny and she's not overweight. But look at the lower body, and she has lipedema. This is also a patient of Dr. Stutz. Bariatric surgery is effective, again, effective for the fat, for obesity fat, but it does not, it's ineffective against lipidema fat. So this lady had a bariatric surgery. Obviously, she lost a lot of weight. You can see from the sagginess and the redundant skin, but she still suffered from the lipidema. And this is another patient that I saw a few years ago in my office, and look at the upper body. It's a different person. And you can see here the scar from the bariatric surgery. I think she had Roux-en-Y, and she lost a lot of weight, but primarily from the belly. And you see the upper arm look like empty, saggy skin, but she still has tenderness there, because when you pinch the skin lightly, it hurts because of the lipidema fat. And obviously the lower body from the waist down, including the buttocks, are huge. But she has two bodies. She needs different size of clothing for the upper body and a larger size for the lower body. Well, since conservative treatment can temper and only slow down the progression of lipedema, and since there's no definitive medical treatment for lipedema, then when despite all non-interventional or conservative treatment modalities, despite all these, patients cannot resume normal ability to perform the daily activities, then we have to start to think about liposuction. before we start liposuction, we really have to optimize the decongested patient and try to exhaust all the available conservative treatment. I show this slide just to show that here's the skin, here's the tibia. She has about almost 5 centimeters here. You can see 4.88 centimeters between the subdermis and the tibia. And all that is lipedema fat, but there's hardly any interstitial edema. It's all lipedema fat because this lady was well decongested and now she's ready for surgery. Lymph-sparing liposuction. Here comes the sun. The lymph-sparing liposuction. Well, for years until the end of the last century, we call it the old and the bad. Lipidema was looked upon mostly as a cosmetic or aesthetic dysfunction. So they applied cosmetic technique for liposuction, dry technique, large cannula. They went in all directions, crisscross, they passed the cannula. And the results were in many cases restructure of numerous lymph channels and unacceptable result, anesthetic result, and most importantly with secondary lymphedema or lipolymphedema, stage 4. At the 90s, Conley in Germany really applied and developed lymph-sparing technique for lipidema without damaging the lymphatic system. In 2002, they applied the tumescent lymph-sparing liposuction in Germany, that by Bariatric, and a few years later, actually the German Society of Phlebology adopted lymph-sparing liposuction for the treatment of lipedema. It's a complementary to conservative treatment modalities. There are 2 techniques for lymph-sparing liposuction. One is the tumescent, and the one is the water jet assisted liposuction. The tumescent, basically very quickly, tumescent, you infuse liters of fluid to the subcutaneous level. Some have 5 or 6 liters, some even more. And the purpose is to swell the tissue. To swell, by swelling, it kind of put a lot of fluid between the globs of fat. You infuse a lactated ringer or normal saline. Inside you put a different kind of local anesthesia, any kind of caines, and add some epinephrine and a little bit steroids. And basically, by spreading and swelling the tissue, the shearing forces are minimized. But you come after that with the cannula to suck the fat out. You have to wait about an hour, even longer, for all this fluid to spread by osmosis into the surrounding tissue and into fat cells. The water jet assisted liposuction, or we call WAL, you infiltrate the fluid the same way, also small cannula, but you don't have to give liters. You just have to get to the point where you give anesthesia and some vasoconstriction. So usually you need 1.5 liters or 2 liters instead of the liters that we saw before. And you can start aspiration immediately. You use the water jet comes in a fan shade, and I'll show you in a minute. And obviously you have to be try to be along the axis of the lymph collectors in both ways. I have you see the panel on the left, that hangs in my office where I operate, because every time I have to turn my head, not every time, but often I have to turn my head and remind me about the orientation of the lymphatic collectors. They not only go from up, down, many places they go across, in the buttocks, in the belly, and you have to take under consideration the watershed lines. So that's important, but that only addresses the collectors. I want to look at this busy depiction of the lymphatic system, and it's important because if this is the skin, This is subcutaneous fascia that many times in a lipedema patient, it's just totally disintegrated. And basically, this is the subcutaneous layer, okay? And look at all these, and these are the collectors, the going kind of longitudinally. And these capillaries and pre-collectors, the capillaries are underneath the skin, and the pre-collectors are crossing from the skin all the way to the collectors. And this area here that I point out, this is where most of the lipidema fat accumulates. And as I showed you before, the distance in some patients between this point and this point can be up to 2 inches. So obviously, you have to consider all these pre-collectors, and when you do the procedure, and that's why, and that's my only personal point of view, is that I would like to use, I don't like to use heat energy that may just coagulate these collectors, number one. Number two, I don't want to get too close to the skin because I can destroy these capillaries. So two things you have to in this subject, and that's a topic for another talk. Two things to consider about the lymph-sparing liposuction is not to destroy the collector, so you don't get too deep, and to avoid destruction of the pre-collectors at the capillaries, and therefore you don't use heat and you don't go too close to the skin. That's a machine. That's the machine that we use for the water jet assisted liposuction, or the WAL. It's an inexpensive machine. It's a workhorse, never break, no maintenance. It's really a good machine and does the job. So you just hang here the bags of fluid, and you connect this tubing. This is the inner cannula, and that's the outer cannula. I'll show you immediately what I mean by that. And you can adjust the jet to come at different frequencies, high frequency, low frequency, and that adjusts also the power of the jet. So here you see there are two lumens. This is the inner lumen that sprays the water, and the outer lumen that accumulate the fluid that you suction. So this is out, this is pushing fluid out, this is under suction. I don't know, this one doesn't work, but I wanted to show, let me see once more. No, it doesn't work. But basically you can see, I hope you heard me, how the jet comes. It doesn't go coaxial, it comes out in an angle, so you can go parallel to the skin and it will reach the skin and numb it. And you see here, comes out here and return to the suction holes here. Oh, this one will show. So here you see on this panel, you to mess the seal, you really swell it, so you break kind of the fat to different globes, and then you suck it out. 2 steps. You infiltrate, wait an hour or so, and then you suck it out. On this panel, this is the water jet. You see, it comes in an angle. At this point, you don't activate the suction, so some comes in, but it's primarily now you activate the suction, and you continue to eject the fluid, but it collected through the suction pores. Oh, okay. Just quickly, some papers that summarize the result. This is Dr. Schmeller. Published it 8 years ago, 114 patients, all female, all were operated for pain. They had average of 3.3 procedure. That's very important because you cannot take all this fat in one session and you do it in the office. It's all office procedure. So you have to divide to different sessions. And you see the average, that's how much infiltration we use, that's how much fat they removed. And when they assessed the patients, I believe it was several years later, I forgot the exact number of years afterwards. Actually, they asked a different scale of 0 to 5 questionnaire, but different symptoms, and each of them really improved markedly. And the combined score from 2.8 went down to 0.88. And this was follow-up up to 82 months. So that's quite good intermediate to long follow-up. This is another paper from Bariatric. Meanwhile, he published another paper, more update, very, very similar results. That's for the same paper. He used a different questionnaire to score the symptom. He went from 92 to 39. That's a cumulative score. That's an important paper by Dr. Stutz. He wanted to prove that the water jet assisted liposuction is indeed a lymph preserving procedure, lymph sparing. So he took the aspirate, the liters of aspirate that he collected from 30 patients. He centrifuged them and subjected the infernatat to immunohistological, histochemical markers for vascular endothelium and for lymphatic endothelium. And from the 30 patients, all had a vascular endothelium, whereas only 2 out of the 30 had lymphatic endothelium, suggesting that the water jet assisted liposuction preserve the lymphatics, and indeed it is lymph sparing procedure. How much is not too much? In other words, how much fat can you take in one procedure? That's a very common issue that comes up. Basically, we do it under local, we do it in the office, and there's some limiting factors. Limiting factor number 1 is the risk of overload. Other one is the toxicity of all the caines, all the local anesthetics that we infuse. And another factor that's very important, how long patients can remain comfortable while lying down on her back, changing from side to side, but it's not comfortable. So these are really the limiting factors. I prefer the water jet assisted over the tumescent, but I have to say that people are use the tumescent method, they have as good results. So, but that's my preference because I use maybe 10 to 20% of the amount of fluid that needed in the tumescent. I save the time. I don't have to wait such a long time. Can start remove the fat immediately. And because I use less fluid to numb, I probably can do more per procedure. Okay, quickly go through the procedure. First, patient stand and we mark her. Then she lies down and we inject, here you see we inject local anesthetic in the small area, just a small wheel of local anesthetic. So we are going to make a small, maybe 5 millimeter or less cut through which we can introduce the cannula, which is 3.5 millimeter, and infuse the subcutaneous plane with this solution. We don't have to, we are not trying to swell it. We just aim to numb it and to have nice effect of the epinephrine, so they'll become the blanch and minimize the bleeding. And here we are going to suction her. You see she changed position from the belly to the side, to the back, side to side, because the patient is 100% awake, extremely important part of the procedure. And when she can, we ask her to move her feet because we cannot put pneumatic compressions over the legs, and we just suck the fat out. And then you see how much fat she lost from the saddlebag area. We dress it. We stand here. We try to drain as much fluid as we can through the incisions. We press it, we get it out. We do not suture the access point because we want as much drainage as possible. And after she rests, she has rest for a while, hour or two, they can go home. We encourage them to ambulate a lot. We try to continue the mother lymphatic drainage, and they keep the garment on top of her legs on the lower body for 2 weeks. They take shower with it, they keep it for 2 weeks. So that picture I took in my office. So you see here on the right, this is my machine, old horse, works like hell. Very, very good, very efficient. Never had to call a repair, nothing. Just sometimes you have to change the filter here. So here you see the bags hanging there, and from here goes to the patient and come back to the canisters. This is the newer machine, the Evo machine. I tried it once, and that they were bought for me to try it. And actually, I did one leg, first leg with the Evo, then I moved to the old machine. And actually, Penn said, "Hey, Doc, can you move back to the trying to do it again with the Evo machine?" Because she felt better. So that was actually an important point. So I'm just trying to predict what I'm going to be asked. I'm going to show you here, for example, in large number, I use 2 liters for infiltration, and for irrigation, to irrigate the fat out, I use 12 liters. So total of 14 liters. And that were accumulated in the procedure, 6 containers, and each of them had 3 liters. You see there's 3 liters. So total, we took out 18 liters. The lower part, the infant natant, which is fluid with very little fat, we got a total of 14.4 liters. And the supernatant is 3.6 liters. So you have 18 total here versus 14. So that's about what we usually get. With the 4 liters, number one, a lot drain on the bed through the holes. When the patient moves to side to side, a lot drains accumulate on the bed, then on the floor, and some absorbed to the blood system. Pain control, that's a major issue. There's another completely separate subject, how we control the pain, how we keep the patient comfortable. We had recently another webinar on that subject, and if you like more information, I invite you after that to send me email, and we can give you the link because it was recorded. Basically, what I'm doing the night before surgery, I use different local anesthetics. I use it doesn't matter which kind right now, but different anesthetics, local anesthetic, different combination of them. I inject over the arm, wait half an hour, and I pinch the site and see which one is the more effective. By the way, the bruise in lipedema patients, it's always bruised there. That gives me confidence that I'm going to use a good solution, effective local anesthetics, and give the patient some sense of confidence that we are going to use something that will work. In summer of 2018, I added the nitrous oxide for anxiety and pain control. This machine was built for dummies, really. You cannot go wrong with this machine. You can just turn it on and off, and when it's on, you can give only 50% nitrous oxide, 50% oxide. You can give more, you cannot give less. And it's all, you don't have something that attaches to the head, like something you see, attach it to the back of the head, and you can give and give and give. Basically, patient take it by herself. So usually 5 inhalations, that's enough to make her feel good and relax. So we avoid any side effect. Now that's important slide that I quickly explain to you. This group represents patients until August 2018. And here you see that we use ropivacaine and carbocaine. That's my preferred local anesthetic in both infiltration solution and in irrigation solution. When I started using nitrous oxide, I kept the infiltration solution the same, but I took the local anesthetics totally off the irrigation solution by adding the nitrous oxide. So the total amount of fluid we use is about the same, 13 versus 14 liters. The total ropivacaine and carbocaine cut by 1/2 between the two periods by using the nitrous oxide. And the patient did not have more pain. They were not more painful. And that's how we give it to the patient. The nurse, when the patient said, hey, I want a little bit nitrous, they love it usually. Maybe some they ask for it, even they don't need it, but that's okay. So give 5 inhalation, that's all. 5 minutes between each round, and they really feel good. And they can drink, they can eat, they can talk, tell jokes, you name it. So in summary, it's very important to know that, I'll start at the bottom, liposuction for treatment of lipedema is not for cosmetic improvement. It's very, very important. And if you need to deal with insurance company, they have to understand it, because they all say that the patient wants it for cosmetic improvement. And the point is, it's not for that. Not only that, it's not for that. Cosmetic improvement will be minimal, and if at all. So that's a very important point. We do it in order to be able to restore normal life and to change this vicious cycle that you spoke about, that more lipedema, more obesity, more opacity, more difficult activities, etc., etc. We try to help to restore ability to walk, stand. Pain is a huge issue to try to restore the gait, so hopefully they will not need to undergo a knee replacement that many require. And so trying to avoid or stop joint deterioration, resume productive life, go back to work, take care of the family, and prevent lipolymphedema. And not less important, really help the depression, anxiety, and self-esteem. Just to show you, I don't like to show pictures before after. Everybody wants picture before and after. I don't like to emphasize the point because this issue, because the cosmetic improvement is not the goal. And I don't want to have this attitude, oh, I want to look. I know and I respect that everybody wants to look better, and they will look better, but that should not be something that a person that part of our marketing or say, oh, it's great. I think the issue is really the other issues I expect. Nevertheless, this woman, she was at that time, I think 39 or so. Look how big her hair up here, and a few months later, much smaller. Just a quick run. We did a survey of women, 20 women in the US who underwent the WAL procedure. All of them had pain. That was the indication. I don't go through that, but basically the whole spectrum of the age, and basically all these measures of the complaint improve markedly if you compare before and after, and the cumulative score went from 31.5 almost to 14. Give that. That's how they stay healthy, stay away from each other until we're all out of this stupid coronavirus. Wish you good luck. And this is my email. You're welcome to write me any questions if you need any further help. Thank you.
Thank you, Dr. Shapira, for your very great and informative presentation. So we have a couple of questions. Some of them you answered already, but some of them not. And I'd like to start with the first question that I have here. In case if stage 4, that is lipolymphedema, would you use water jet liposuction to treat it? Number 1. And what would be the differences in the liposuction technique compared to a stage 3 lipedema?
Okay, that's an easy one. I will use the same technique, and it's not different from stage 3. Maybe the difference is how much I want to decongest them prior to surgery. Because as you remember, I want to optimize, I don't like the word conservative because some of them are new methods, like the pump, the Flexitard, these are new methods. It's not conservative, but I want to optimize non-interventional treatment modality. It's important to show that we optimize it, we did everything we can, we cannot do any more until the patient disabled. That's the time to address it. So only the patient with stage 4, it will take more to get it to this plateau that conservative treatment cannot add anymore. Otherwise, it's the same. I may need more procedures. That's a different story, but the technique, the same.
Thank you. The next question is, how do you treat the gray color in skin that sometimes appear after lipedema surgery?
Discoloration of the skin, you mean, Larry?
Yeah, so it is the gray color in skin that sometimes appear after lipoedema surgery. Have you ever experienced that?
I don't, but if you remember the slide that I showed, the lymphatics, the right panel, I think if you go too superficial, and I have a nice slide about it, I didn't want to show because you will tell me that I take too long, but there's a nice slide that I'm showing that if you go too superficial and you're really close to the dermis, I think that may lead to scarring, discoloration of the skin gets very hard, very difficult to heal. That's why I think you should not get too close to the skin so you don't damage these lymphatics, you preserve all these lymphatic capillaries. And frankly, I think the lipidema fat is not the very superficial fat. It's not the superficial fat. If you remember the one, the ultrasound, the superficial fat, the fat that just underneath the skin, it was a dark color. And when you pinch this fat, it doesn't hurt. When you pinch the whole fat, the deep fat, that's what hurts. So I don't think you have to go too close to the skin. And I think by doing that, you really avoid a lot of damage to the skin.
Thank you. Another question related to the skin. Do you do skin resection techniques at the same time at lipedema surgery? Any tips about it?
The answer is no. First of all, I'm not originally plastic surgeon, I'm cardiothoracic surgeon, so I will not do that, number one. Number two, that's a very, very good question because many patients concerned about sagginess of the skin. That's a very important concern because everybody they want to get, first of all, they want to get rid of the pain and the symptom. But second, they want to look good. And it's very legitimate. My personal bias is to stage it because almost in every lipedema patient, there's some stretching and abnormality of the lymphatics. Get the fat, so the way I do it, and Dr. Stutz does the same, get rid of the fat. Give it a chance for the lymphatic to heal. Give it a chance for the skin to contract. And the skin can contract, can take a year, year and a half, because that's how long it takes the collagen to build. Let it retract. Many times you'll not need any skin excision. I think to do it initially, I think it's somewhat premature. And if after a year and a half, there's still concern about the skin, if you resect the skin, I think it's much less complicated because you have normal lymphatics, you have everything normalized. And by then, you can address it like any other patient. So no, I avoid it. I avoid it at the same, doing it at the same time.
Okay, in your experience, is the patient's recovery more painful after liposuction because of the pain component in lipoedema? I think the question is, Is the recovery more painful for lipedema patients than it is for patients without lipoedema?
A good question. I can just say my impression, it's not more. No, I don't think it's more. But lipoedema, remember, many patients, that's important, have hormonal. Lipidema is very influenced by hormonal changes. And for example, if you do it close to the menopause, in the perimenopause period, they may experience much more pain after that because of the hormonal changes. If I talk about just isolated for any other factors that can add to the pain, I don't think it's different. I don't think it's different. And actually, the greatest thing is to hear from patients is when they step down from the bed and go to sit and rest for about an hour and two before they're going home, they say, wow, it feels so good. Or the knee doesn't hurt. And I feel good because of the local anesthetics. It's still there. The ropivacaine, that I put can last hours. But if they say that the knees feel better, that's great, because that's not from the local anesthetic. It's from improved post gait.
Okay, the next question, you slightly touched that, but maybe you can comment that here a little bit more. The question is, Dr. Shapiro, when you perform liposuction on a lipoedema patient, are you keeping aesthetics in mind or just removing the diseased fat? I'm concerned about having devotes or even worse, asymmetrical shape.
Okay, very good question. I'm always concerned about aesthetics. I said it before. The question is what I can do. What can I do at this point about it? That's a question. Because personally, and I think most people who came from a background of lymphology and lymphatic medicine, I think they'll concur with me. At this point, remove the fat and keep in mind to avoid hurting the lymphatics. And I explained it. Now, another reason why I go backward to another slide, if you compare the tumescent solution to the WAL, technique, one of the reasons I do not like tumescent, besides not to want to wait such a long time or large fluid, all these reasons, is another reason. Because when you pass the cannula, you pinch, I'm right-handed, so I pinch the skin, I grab the whole, the fat between with my left hand, which is the smart hand in this case, and I pinch it to know how far I can suck. If it was very swollen from the tumescent, I think the chance that not be even or accurate or symmetrical is higher. So the fact I infiltrate it with only 1.5 or 2 liters total, rather than 7, 5 or 7, I think that gives me a better chance not to err in terms of cosmetic and to get better results. I don't know if it helps, because that's a very good question. All the questions are good, but I think that's the way I look at it.
Okay, here's the next question. Most lipedema patients are large. What is the maximum amount of fats that can be taken in each procedure? I think you answered that. That is, first of all, depending on the area. I think in the US, it's 4 to 4.5 liters maximum. In Europe, it's different. Can you confirm that, Dr. Shapira?
Yeah, yeah, but I tell you, it's the amount. At the night before surgery, when we talk with the patient and talking about what to expect and all that, obviously patient want to take as much as possible. But when you come to the procedure, you know, they get tired. It takes a lot of energy out of you. We put music, we entertain them, we feed them during the procedure, we drink them during the whatever you want. I mean, they can turn around, they can move around. Still, it's tiring, and they reach a point that enough is enough. So it's not only physiological issue of a fluid imbalance, all that, but it's only comfort. So I really think there's a good correlation between the two issues, the physiological issue that we are limited to whatever, 3 or 5 liters, and the tolerance.
Okay, so one question here is, does lipoedema pain go away after liposuction?
The short answer is yes.
And yeah, that's I think too. Do you use? Go ahead.
That's why when we plan the different procedures, and on average, patients has close to 4 procedures. We do the first procedure. I apply to the area that's most harmful or painful to the patient. And usually it's the inner thighs, inner legs, between the groins and the ankles, but not always. It's used the most. Sometimes the hips are more painful. But once you do it, patients say that they have pain after surgery, but it's a different pain. They describe more as a surgical pain, like surgical sore, that when they start to move, they walk, it kind of softened the issue and it relieved. The lipidema pain really goes away.
Thank you. Do you use local anesthesia plus sedation when the patients are positioned face down?
I'm sorry.
When the patient is in a face down position for liposuction, are you using local anesthesia and plus sedation in that cases?
Okay. First of all, I never use mech anesthesia or IV medication, none of that, number one. Number two, I never put the patient in prone position with the face down, like you saw from in the slide that I took from Dr. Stutz. When I do the back or the buttocks, or they're always on the side. I'm concerned a bit to be in a prone position because really from breathing issues, it can be very dear, especially patients some element of COPD, I think can be bad. And frankly, I don't need it. I mean, in supine position or turn from side to side, I can get anywhere.
Okay, here's the next question. Why do the bags contain more fluid than fat? I have seen photos from other surgeons that have minimal fluid and mostly fat. Does it mean you're removing less fat?
Good question. First of all, what you saw from, I don't know what technique they use in other surgeons. When I'm doing, for example, liposuction for cosmetic reason, I use a smart lipo, use laser. I'm not concerned much about the lymphatics, the heat energy and all that, etc., etc. Then it's the opposite. I get much more fat than other fluids. Here, you have to understand, whoever asked the question, that I use fluid to irrigate the fat out. And that's about what you get, because you have to use about on average like 3 cc of fluid to irrigate in order to push 1 cc of fat out. And frankly, it doesn't bother me. I mean, I give as much as necessary just to reach the endpoint that I want to reach. But I'm glad about the question. If you remember the slide, maybe a few slides before, when I calculated, the total fat I removed there was, what, 600 times, but I think it was about 3.5 liters, 600 times 6, it was 3,600. That's a lot of fat. Now some of that is still fluid because it's kind of liquefied fat. It's not pure fat, but that's a lot of fat. I don't want to go more than that for safety reasons. So what you have to compare is only the supernatant, the upper part, the fat, not what below. Below is just to get this upper part out. I hope I explained it well.
Thank you. Here's a general question, whether or not lipoedema is more common in Western population versus the Asian population. Do you see differences in that?
I don't know.
Yeah, that's a good question. So we can investigate a little bit and answer that question a bit later. And coming to the next question, what would you use? Would you use that fat for lipofilling? So fat that you're harvesting for lipoedema patients. Would you use that fat for lipofilling?
Only if I want to spread the lipidema to other parts of the body. I don't think anybody wants to do that, right? No,
Yeah.
I throw it away. It goes. And actually, in Germany, they use it for recycling, for energy. Believe it or not.
Yeah, thank you. What percentage of your patients have liposuction for lipoedema covered by health insurance? Very interesting questions.
Oh God, that's a heavy one. You have to. Okay. The bottom line is, I know, but 75 to 80% of my patients eventually, and I underline the word eventually, get covered by insurance company. Stephanie, who is our coordinator, was my first patient. She was naive enough to expose herself to my to my instrumentation after I came back from Germany in my first patient, and very compassionate. And so we made the decision together that that's our ethical, medical philosophy, that we really should try to work hard to get patients covered by insurance company, for the simple reason it's a disease. It's not luxury. It's a disease. Also, it's stupid for them not to do that, because you can save years of inability to work, misery, the risk of knee replacement. There's financial rationale for them to cover, but that can be a miserable road. And I gave a talk about that in the Fat Disorder Research Society, FDRS, about the miserable road to get covered. That's a long time. Usually trying to get it before surgery, so they don't have to spend money out of pocket. Sometimes it doesn't work, so we have to apply for appeal, then another appeal, sometimes external appeal, a lot of paperwork, a lot of effort. But the bottom line, I would say that 75 to 80%, maybe even 80% of our patients, we get coverage.
Thank you. How often do you see a post-operative seroma? Is that something that
I don't think I ever had to drain seroma. I think it's very rare. And the reason is that we empty whatever we can in the operating room before they stand up. After they stand up, they wear the compression from the chest down to the ankles 24/7 for 2 weeks. And after that, 24 hours on, 24 hours off. I give them the short stretch wrap that immediately after surgery, and they walk a lot. So I really think it's very rare. And keep in mind, we keep the small access cuts open. We don't suture them. So there's a good way for all this fluid to get drained.
Thank you. We have a couple of more questions. The next one is, what do you recommend after surgery to promote skin retraction?
I wish I knew. I wish I knew. I think what happens is, but one thing I do think it's important is to counter the gravity, the effect of gravity. For example, remember the woman that I said that we are holding her surgery because of the coronavirus? She will have very large, empty pocket of skin at the inner knee. You remember this patient? By the way, we could drain a lot of this fluid, but different tricks to drain this area. But she'll have large one. So what I'm going to do with her, I'm going to give her such a compression, actually we prepared it, that will keep the skin up. Because if it hangs down all the time, the retraction, I mean, the building of collagen, the collagen will establish itself in the position when they hang down. I want to build collagen and elastin and all the healing to take place, all the scarring underneath the skin to take place when the skin is elevated against gravity. And I think that will give us the best chance. Massage, but I don't know if anything else will do that. That's the one thing I think to avoid, to minimize the effect of gravity. I think that can help.
Thank you, thank you. So as far as anti-inflammatories, would magnesium be something good to take for lipedema?
Yes, and take it myself also.
Thank you. How frequently you find that arms grow in volume after liposuction in legs?
Well, say it again, I'm sorry.
How
often I found the arms what?
So wait a minute. Wait a minute. How frequently you find that arms grow in volume after liposuction in legs? Have you ever seen that?
No.
Not. Okay.
But I want to say, I mean, but I think probably the person asked because some people say, okay, we did your legs, for example, and now my belly gets bigger, other parts get bigger. I think that probably, but I don't think because I think that's the reason, because we didn't touch the arm at that point, and the process continues. The process of lipidema continues. So if there's hypertrophy of fat cells, it will continue in this area. As far as my experience is, it does not continue in areas that will remove the lipidema fat. It does not continue this area, but there should be more follow-up studies, long-term follow-up studies, which nobody have done that. Yeah, that's really the way I look at it. It's progression of the disease in areas that were not touched yet.
Okay, so what's the minimum weeks you should wait between surgeries?
I used to do 2 weeks, but Stephanie told me to stop doing that, and now I wait a month in between. Just let them recover, let them heal, get over the post-WAL skin soreness, and many patients, not all, but many patients have some drop in hemoglobin, which is not entirely clear to me why, because blood loss is really, in most cases, I wouldn't say there's no blood loss, but the blood, this hemodilution, which I think in part, maybe part is blood loss. I'm not sure why they drop hemoglobin, but so therefore I think that the 1 month, 4 to 6 weeks, I think it's a good period to wait in between. And I usually check the hemoglobin again before we going to do the next procedure.
Thank you. Is it better to have surgery before or after pregnancy is one of the questions.
It's one of the questions I'm hoping nobody will ask. Oh, that's something I will ask probably Dr. Herbst. I think we have to, but I'll have a diplomatic answer. We have to assess it from patient to patient. We have to individualize it. For example, if a person is 31 years old, she really eager to have another kid, and I would say if you can tolerate the disease, probably wait. On the other hand, if the disease is intolerable, impossible, then probably it's time. Do it, or do at least the areas that are most bothering, the most difficult one. And it's something we really should consider, because lipidema is very affected by hormonal balance and fluctuations in hormones. So it might get worse. It always gets worse during and after pregnancy. So you have to weigh the pros and cons about waiting or do it before. It's very difficult. Same question, by the way, can be asked. Should we wait for menopause to get over menopause or go do before? I'll give the same answer. It's all should be individualized and see how bad is the disease.
Okay, here is, we have 4 or 5 more questions. And how does age factor into the surgery? Do you find older patients have as much success regaining mobility and aesthetics when it's stage 3 and 4?
I don't think it's affected by age. I think it's more affected by stage. I think I've done my older patients, I think 77, I think so. But I think it's more stage related, not age related.
Here is a very interesting question. Have you ever used laser? There are a lot of doctors in California that are using it with great cosmetic results, which is a big draw for a patient that already suffers from depression because of their shape. So it is an interesting question to direct compare.
Well, obviously I'm biased because I'm not using laser. I have a laser machine that I use in other procedure. I have the Smart Lipo Triplex, a very good machine, does excellent job, but I never ever use it for lipedema. And I think I explained that I'm afraid to hurt the lymphatics. The lymphatics are so delicate. If you take the temperature of the laser and put the laser fiber into an egg, just put it into the egg, it will coagulate, right? So the same thing will do to the lymphatics. So why we have to take the risk? But I have to say, the surgeons who use it, either the laser or I forgot the name that are using. It'll come back to me. They have good results. They say they have good results. Definitely, there's more skin contraction when you use heat. But I don't know how much skin will contract just by the natural healing. And what I say to patients, if in a year and a half you're still unhappy about it, that's a time to do the skin excision. But that's my personal bias. I'm sure there are other people have other opinions.
Thank you. Last question is, do you have any suggestion on nutrition, or does your office offer any type of nutritional counseling?
I don't recommend seafood diet because seafood, in me, you see food and you eat it. So I don't recommend it. I also follow what I said, that if man made it, don't eat it. I think that's really, these are the most important recommendations. Personally, I noticed that all patients who could be on keto diet, which is really a very good anti-inflammatory diet because it minimizes carbs, it minimizes the insulin level in the blood, minimizes the spikes in insulin. Those who can tolerate it, because some people don't like it, those who can tolerate it, they love it, and they definitely have less pain related to the lipedema. They feel, a common statement is, I feel less inflamed. I don't understand how to translate this sentence, but I don't give them the word. They say themselves, I feel less inflamed, I feel better. The pain in the knees, the pain under pressure, all that is still there, but they feel better. So the bottom line is no seafood, no man-made, and try anti-inflammatory diet. And I refer all my patients come for consultation, and as a preparation for surgery, I refer them all to some website they really can learn how to apply that to their own life. I think it's extremely important. And now I also have to mention in this context that Stephanie, that I mentioned so many times, our coordinator, she's now probably as we speak getting her certification for complementary nutrition. And I think she will be a tremendous source for information for this issue. And by the way, she does not like the keto diet. I'm on keto diet myself. She does not like it. She could not tolerate it for a variety of reasons. But I do no man-made food, no seafood, anti-inflammatory diet.
Thank you so much, Dr. Shapira, for your wonderful presentation. Oh, sorry?
My wife asked, what's man-made food? I mean, all the preservative, all the chemical, processed food. I mean processed food, right.
Okay, sorry for interrupting you too early. What left is thank you very much, Dr. Shapira, for your wonderful presentation and your question and answers. Thanks to all of you for staying with us, listening. For all future webinars, please refer to www.chaosdromamerica.com. We would love to welcome you for the next webinars. And what left is to wish you all a nice day, a good night, whichever time zone you are. Please, Dr. Shapira.
Larry, I just want to say, you have my email there, and I welcome people want to contact me or to contact Stephanie. Contact me and I'll refer to Stephanie for advice, for directions. I think Stephanie is a phenomenal resource for from her experience before, during, and after the procedure. But all kinds of issues that you have to deal with after the procedure, great source, and also now for nutrition, for complementary medicine. And if you have any questions to me, please write me. I'll be happy to get back to you. Thank you, Larry.
Thank you, and goodbye.